Back, everybody. Thank you. We will go. Our next break should be just around 5 p.m. Eastern, 2 p.m. Pacific. And we'll carry on here, just finishing up on hypertension. And as we go through the next two sessions, we're one down, two to go, we'll be getting into topics that are sort of, some of them are really fairly mainstream, and some of them are a little bit less common in the exam. We put them in there because, again, Dr. Shamroff will talk about sort of how EBOG kind of telegraphs and lets us know what's important for the exam. Structured cases very commonly come out of topics we're going to talk about, for which many of us may actually not have cases like that on our case list, but they do seem to be very common topics, and they're the topics of publications from ACOG. And so they find a way to test us for them in the exam. As we are continuing on here, just our candidate from break, question right before the break was asking about category 1, 2, and 3 fetal heart rate tracings. And I appreciate, please do put a question up there. I'm sort of trying to take my time and go along here and trying to emphasize all the important things. Sometimes things may go by a little bit more quickly than you'd like, and please do let me know if we should go back over everything again. So again, I do want to mention once again, the accelerations are in a category 1, 2, 3 fetal heart rate tracing scenario. The accelerations don't matter. They can be present or absent. Category 3, when we're looking at baseline, can actually be normal or tachycardic or bradycardic. The variability can be one of two things. It can be a sinusoidal pattern, or it can be absent variability. Accelerations do not matter. They can be present or absent, but what we're looking for is then a pattern of late or variable decelerations. Early decelerations actually don't matter, but we're looking for late or variables. So baseline can be anything. Variability, either absent or sinusoidal, and we're looking for recurrent or patterned late or variable decelerations. Now, we were actually talking about in patients who had preeclampsia in a previous pregnancy, how we manage the next pregnancy. So we talked very briefly about medical history screening for risk factors for preeclampsia. We mentioned that although there are a lot of commercial testing kits out there, that ACOG does not recommend any of them, doing a urine protein creatinine ratio assessment at the new intake OB visit in the new pregnancy is very important. A patient with preeclampsia is someone who may actually have become a chronic underlying hypertensive in the meantime, or may have been latent. So we want to screen these people at the first visit, just like we do for our patients who have known or diagnosed essential hypertension. What can we do to reduce the risk of preeclampsia in this or in the next pregnancy? And that's where we come to the low-dose aspirin, 81 milligrams per day. Now, on this slide, I want to be careful, because when I read it through, I thought this slide was a little confusing. When we're talking about high risk and low risk, which is this slide and the next slide, we're talking actually about the risk factors to recommend low-dose aspirin to our patient. So on this slide, high risk factors means you only need one of those. Any one of these criteria right here is an indication to offer your patient aspirin, 81 milligrams a day. On the next slide, the low risk, we need two at least or more of those risk factors to recommend low-dose aspirin. So on the high dose risk, anyone who, again, is hypertensive or has had preeclampsia in the previous pregnancy, because they're suspected hypertensive patients, should be offered. Again, renal disease, one of the early markers of end-organ disease related to hypertensive disease, and that by itself is an indication. Any multifetal gestation, as we mentioned, pre-gestational diabetes, just right in there, pre-gestational, not gestational diabetes, which is a different animal that occurs into the second trimester pregnancy, but where someone comes into the pregnancy as a diabetic, we're concerned about the risk of microvascular disease. And again, autoimmune diseases, antiphospholipid antibody syndrome, leukoid diseases, anything autoimmune as well. Now in this one, don't know about you all, but in our practice at the moment, anywhere between a third and a half of our patients, based on having two of these criteria, do get on aspirin at any time. So if I have someone who is nulliparous, and remember, obesity means a BMI over 30. And we have a minority of our patients these days who have a BMI under 30. So being nulliparous and have a BMI over 30, having either one of these two, plus being of African-American race, or over age 35, we have a lot of these. So if you add up any two of these in any given practice, it's likely that at least a third of your patients may be candidates for low-dose aspirin. Now, what we do notice is that it is not universal or very common that people will actually put that over there as one of our interventions. The way the OB case list works is on the left-hand side, we have the antenatal problems, and then we have the problems that occur during the labor and delivery hospital admission. And then to the right side, we have all of our interventions. And ACOG does intend that for each of the problems we put on the left-hand side of the risk, of the risk factors, there will be one or more interventions there. So if you have a patient and the GP data show you that this is her first pregnancy and you've listed her as 36 years of age, the examiners are going to expect, or per BMI is 36 at registration, the examiners are going to expect that aspirin is in there, and it quite often isn't. So do go through your places, identify those patients by this list who would have one or two risk factors, and just make a note. And remember, just in the exam, they may ask you, so I see here you have a patient who's 37 years old and she's nulliparous. What are your particular considerations at her first OB visit? And that's a very open question. And in the stress of the examination, it's very common that we may not actually remember to say, oh, she's a candidate for aspirin, because we're thinking about all the other stuff about antibodies and higher risk of SAB and hypertension diseases and things like that. But do keep this on your radar screen, because they really are listening for things like that. And their favorite thing in the exam is to say, is there anything else? And you will get so sick in the exam of them saying that. But what they're trying to do is get you to think about the one thing that they were just wondering about. And they will do it a couple times, but they can't clue you or guide you to that. So do keep in mind, this is one of the important things these days in modern practice. Do know these risk factors and go through and vet out in your cases the people who are greater than 35 and the last pregnancy was more than 10 years ago. They get aspirin. She's first pregnancy and she had an IVF pregnancy. She gets aspirin. So along with that, so those are the risk criteria. I wanted to emphasize that. Then, as far as delivery, remember these days that for preeclampsia without severe features, if it develops and the patient is 37 weeks of gestation or more, delivery is appropriate. For severe features, 34 weeks of pregnancy or on, depending on what else is going on and indications for delivery, and maybe a discussion with MFM, and sometimes shared consultation with the patient. But preeclampsia without severe features, delivery appropriate at 37 weeks or above. For severe features, appropriate at 34 weeks or above. And they're sort of waffling right now between 34 and 35 weeks, but I think we can stick with 34 here for this year's exam. Now, when we come to things like eclampsia, we'll practice this in our mock oral session. The common questions are, how do you evaluate and manage your patient during an eclamptic seizure, which is really just basic support and oxygenation, and if you can, assessing the fetal heart rate tracing. And how do you assess and manage your patient after an eclamptic seizure? And this is evaluating maternal and fetal status and whether there's an immediate indication for delivery. And if not, then so how will you manage her, given that she does at some point need to be delivered? So do be sure just to go through in your case list and look at if you have any eclamptic cases on your case list, or you have someone with severe features. It's common that they might make this a hypothetical question. Induction is perfectly appropriate after eclampsia. There would have to be very specific indications for cesarean delivery. Our concern for the patient having a recurrent eclamptic seizure is not necessarily an indication by itself. So we'd have to have something else going on for which there was a specific indication for cesarean. And as we go through the season, that's something that we're happy to sort of talk with you about and discuss in our sessions, and if you're doing mock orals or one-on-one teaching with us as well. Then just know basically that the seizure prophylaxis protocol you use at your institution for management of preeclampsia. Do remember that if we get toxicities, calcium glucate 1 amp and stop your magnesium infusion is the immediate antidote for that. Dr. Shamroth keeps us in that this turns up from time to time on the exam. How do we treat a preeclamptic patient with myasthenia gravis? Well, in this case, just magnesium actually a risk for respiratory suppression and arrest. So we can't use IV magnesium sulfate. You can use phenhydranate or dilantin, or you can use Valium or one of the benzodiazepines as a sedative, as an option. Do know just basically in your institution, how do you work your emergency antihypertensive therapy? I think the addition of the oral nifedipine has really helped, because that seems to be very quickly effective in the people who are sort of failing on the labetalol pathway in particular. And do remember that for the pathways you use, know the dosages and the intervals and how you max out. And then if we go to our next line agent, and we're not getting response, we probably do want to consult with, if we have a maternal fetal medicine, an intensive care specialist, someone else, anesthesiologist, someone who could help us with more critical care management if that's not working for us. Then do make a line under here, chronic or chronic hypertension. Essential hypertension is chronic hypertension. Just draw a line under that. Everything below this is what we call secondary causes of hypertension. And we do need to know a few of these for the exam. Because the examiners may ask us about that. I think the important ones, just to be able to name if they ask you for a few, would be renal disease, very common. Renal artery stenosis kind of goes along with that. Sleep apnea, fairly common these days. Drug use, methamphetamines or cocaine, those would be a good 4 right there. If you want to add one more, you could get in Cushing's disease. But the common ones would be renal disease, renal artery stenosis, sleep apnea, methamphetamine. Those actually can lead to, they can be secondary causes that are not essential that can lead to the development of chronic hypertension. And they do ask about this in the examination. And the important thing is that these secondary causes are present in at least 10% of hypertension in pregnancy. And you can probably see which the more common ones are going to be, and that's why they ask about it in the exam. Then in your practice, just be able to discuss, what is your management? Do you go to a beta blocker first or a calcium channel blocker? And just what are the present guidelines? Do remember that we don't want these people to actually have normal blood pressures 128 over in pregnancy. If they are really established essential hypertension patients, we want to aim for about 140 over 90 because we need to keep their blood pressure up given that their vascular tone is a little different and increased. Obviously, we don't use ACE inhibitors in pregnancy. They are teratogenic in the second trimester and they cause other placental and electrolyte issues in the third trimester as well. So then I think we will move on to diabetes in pregnancy, which is our next most common topic, and then we move into other issues from there. So in the exam, the very common progression is for any given problem, tell me, doctor, how do you screen for hypertension, diabetes, thyroid disease, cardiac disease, whatever, in your pregnancy, in your practice? And next, so discuss the screening protocol. How would you begin to manage a patient who actually screened positive for one of these conditions? And that's basic hypertensive diabetic management. What are your concerns for maternal and fetal risks during the pregnancy and what complications can arise in the patient was, in this case, we're calling diabetes. And it will eventually end through, so how do you conduct your prenatal care? What is your plan of surveillance, frequency of office visits, testing, assessments, other things that we need to think of. And finally, it will end up, if they take it this far, with when and how would you deliver your patient. So there's a fairly predictable rubric that works through this. And if this is the sort of thing that you practice to yourself when you're going through your case list, pick someone with thyroid disease and just do that. How do you screen? How do you identify? How do you manage someone with hypothyroidism pregnancy? We'll get to that in a few minutes. What particular problems come up if hypothyroidism is not managed? Are there recommendations for timing and mode of delivery for hypothyroidism? You can apply it to anything on your case list. It's a very good way of just beginning to practice so that wherever the examiner sort of drops in there, you'll have already sort of talked yourself through it and you'll be able to pick up and carry on there from the end. It is a fairly predictable part of the exam. So it used to be that the American Diabetes Association, and ACOG went along with this, had this risk of people who are not routine risk or high risk for diabetes, but they were really low risk. And they were young and they were very slender, and neither they nor anybody in their family had anything approaching an abnormal glucose assessment. And they were all white because every other ethnic group actually is not allowed on this list. And then in 2014, ACOG decided, you know what, no matter what, we should be testing all of our patients, because before that, we would opt these patients out of standard screening. But these days, just remember that ACOG and USPSTF recommends that all pregnant women get screened for gestational diabetes between 24 and 28 weeks of pregnancy. Just be able to discuss in your practice sort of what you do, whatever criteria you want to use, Carpenter-Kustand criteria or any other criteria, just be able to describe the criteria that you use and how you assess your patient. That's all you need to remember. Do consider, and this is something that happens more commonly these days, you don't need to go to a 3-hour GTT if your 1-hour GT is a really high outlier. So if the fasting glucose that you assess otherwise happens to be 125 on your initial intake, if you happen to get a CMP on somebody who is a diabetic, or if your 1-hour GTT is over 200, you can manage them as a presumptive diabetic and you don't need to go through a whole 3-hour GTT. Then, outside of routine screening, when will we do testing for diabetes otherwise? So these are the high-risk criteria. We should know obesity, BMI greater than 40, definitely. Some of us are actually doing them for BMI 35 or older. Obviously, previous diabetic history. Again, greatest chance in this pregnancy is that it happened in the previous pregnancy, or anything else that really strongly suggests that the patient was a diabetic. That would be a previous fetal demise, or it would be previous shoulder dystocia or macrosomia. Any one of these suggests diabetes. PCOS is insulin resistant. That patient would behave as a diabetic in pregnancy. High risk race, actually, I think they're thinking more of Latinx and Hispanic populations in general. The physical inactivity, they actually mean people who are really immobilized or disabled or activity limited in some way due to a disability of some sort. And any cardiovascular disease in a reproductive age woman should prompt screening for diabetes. Someone who is in a younger age range and develops cardiovascular disease, that may be diabetic microvascular disease right there. And as well, of course, any first degree relative. So a mother, sister, daughter with diabetes, automatic early GTT. So again, do go through your case list. And just in there, you may have somebody who is a previous diabetic. The examiners would expect to see early GTT listed on your interventions on the very right-hand side of the case list, and it's often not there. So just remember to mention it to them if they ask you about it and just put you on the list. And that's another important part of vetting your case list. Then do remember, and this is something in our practice that we keep having to remind people about, anybody who has had gestational diabetes does need to get that 2-hour 75-gram GTT at 3 months or more postpartum to be sure that they are not actually chronic type 2 diabetics, which would be very important for their general overall and lifelong care, and also for any future pregnancy. The next few slides are just about the white classification, and no matter what you're doing, I would use the white classification in pregnancy. I would describe your diabetics rather than diet controlled or medication controlled. I describe them as A1, A2, B, C, D for the pregestational diabetics. Most of us don't have F or H or R, but just know them. And I would use those classifications when we are speaking in the exam with the examiners. That tends to go better. So then what is the difference between gestational and pregestational diabetes? Remember that gestational diabetes develops maybe at 18 to 22 weeks, where there's the premenstrual lactogen, insulin resistance develops. So these people do not come into pregnancy as diabetics, and therefore the microvascular disease that we associate with a chronic diabetic, which could affect the placenta and could affect maternal organs, is not really so much present. So these are patients who are better controlled in pregnancy. Their complication rate is lower. They generally tend to be more macrosomic than fetal growth restriction, because their placentas usually have not had the exposure to hyperglycemic levels at very early pregnancy developmentally. And we do need to talk about these organogenesis anomalies, which are right up in here. So the risk of pregestational diabetes is increased risk of loss in all 3 trimesters of pregnancy. Fetal growth restriction, usually more than microsomia. Preterm delivery, pretty much across the board. And in addition to the idea that the greatest risk factor for X in this pregnancy is that X happened in the last pregnancy, is if you're ever asked, so what is the potential risk factor for X in this pregnancy? If you just say preterm delivery, you will be right 95% of the time. Virtually anything that affects a pregnancy and makes it increase in risk in any way does carry some increased risk of preterm delivery. And it's just a slam dunk. And if your mind goes blank, just remember to blurt that out. And once you say that, you'll actually be able to say more stuff. So the organogenesis abnormalities would be cardiac defects. This is the cardiac tube, the neural tube, and kidneys really that develop in this 2 to 4 week window where embryos are developing and where there's exposure to high glycemic levels in people who are not yet controlled diabetics. So any congenital cardiac anomaly, any neural tube defects, the caudal regression, also renal issues, because the renal tube develops at that point in pregnancy. So these patients do need to have careful anatomic screening and usually a fetal echocardiogram, remember, as well for the pregestational diabetic. Gestational diabetics do not need to have an echocardiogram. They can get a good level 2 anomaly screen at 18 to 20 weeks. At that point, they are probably not yet over diabetics. And there is no risk of anomalies in this group, congenital anomalies. For neonatal effects, this is just one of those reference slides to remember for the exam. If you would, just draw a line across right under hyperbilirubinemia, because these are the common things that we see in infants of diabetic mothers. At birth, they'll have difficulty regulating their blood sugar and sometimes some of their electrolytes. They will have a little difficulty with temperature regulation, and because they're maturing a little bit later, their livers may not be fully mature. They may have a little hyperbilirubinemia. They may have a little bit more respiratory issues if they're born under 39 weeks or so. Just it's a slower development of organs in full maturation for delivery. So these are the common things in the top 4 above. The bottom 3 things, much less common in the exam, and they go down there. Polycythemia, respiratory distress, their cardiomyopathy, very uncommon in pregnancy. But remember at least those 4 for the exam. What are the effects on the mom in pregnancy? Well, obviously any hypertensive disease, because that goes along with diabetes, preeclampsia being one of the hypertensive spectrum disorders. Whatever they are dealing with right now as far as microvascular disease of diabetes, may deteriorate during pregnancy. So we're looking at an organs, we're looking at the kidneys, we're looking at the heart and liver, we're looking at the fundoscopic exam is useful. They may develop peripheral vascular issues as well. They have an increased risk for cesarean delivery as a result of a lot of complications that have to do with placental insufficiency at term and other risks for the fetus as well. And of course, a separate risk during pregnancy of TKA if they are poorly controlled. The next step is, well, so tell me, doctor, how do you manage your diabetic in pregnancy? So we would start just by talking with the basic diabetic diet, carbs, proteins, and fat, 1/3, 1/3, 1/3, and you're looking for 2,200, 2,400 calories a day with complex carbs being preferable. How do we divide that up? Note here that it's not 30, 30, 30. We actually take some of the breakfast calories and we transfer them back to the midnight snack the night before. And this helps to protect against the Somogyi effect and overnight hypoglycemia if we load something in for bedtime. And many of us will notice if we're watching our blood sugars carefully on our diabetic patients, that they may actually have really good 2-hour postprandial sugars, but the morning fastings may be high. And if we ask them about the midnight snack, it may be that because they don't feel hungry, they are not taking their midnight snack. And if you ask them to add it in for a week, their fasting sugars will actually begin to behave much better just because of that. So there is really something to that. So 30 lunch, 30 dinner, a little bit of the breakfast calories gets transferred back so instead of 30, 30, 30, 10, it's sort of 15 and 25. And just remember the standard glycemic goals that you look for in your practice and just discuss how you manage those. Then insulin is more and more really the insisted upon medical management in pregnancy. In a couple slides, we'll get to the other sulfonylureas and other medical agents as well, but most of us should be using insulin. And the way to discuss it in the practice is that we usually use a combination of a long-acting and then sometimes with it a short-acting insulin, usually. And we usually divide it up about, for an uncomplicated diabetic, 0.7 units per kilogram of lean body weight in early pregnancy. And we might go up to a unit or more at term. And of that unit or so, we divide it up between the evening and the morning in this way. And this is actually an easy way to remember it. The morning dose is 2/3 of our 1 unit, and the PM dose is 1/3 of our 1 unit. And then the morning dose is also divided 2/3, 1/3 between the long-acting and the short-acting insulin. So morning versus evening, 2/3, 1/3. Morning dose, also 2/3, 1/3, long-acting versus short-acting. The only exception is the PM dose is 1/2 long-acting and 1/2 short-acting. And that also has to do with sort of covering that evening snack and moderating overnight hypoglycemia. But that's a fairly easy way to remember, just 2/3, 1/3 here, 2/3, 1/3 right across there. Then some of us on our case list actually do have other glycemic agents for use of diabetes in pregnancy, and metformin is probably the most common one. The ABOG and ACOG line right now is that insulin should be used to manage diabetes in pregnancy, except in patients who cannot, for some reason, or will not accept insulin. And in that case, we would move to metformin. The reasoning behind this is that really the best maternal and fetal outcomes in minimizing adverse pregnancy outcomes in diabetics across the world, across the spectrum who require medication is established with insulin. And metformin is a little bit less good for that, but it is an appropriate alternative. Glyburide actually is not on the favored list with ABOG and ACOG anymore because it really does have not the level of suppression of adverse neonatal outcomes that we would want. It is considered clearly to be inferior to both insulin and to metformin. A few of us may have glyburide on our case list. We'll simply need to discuss, and that sometimes has to do with what our MFM colleagues are sort of leaning us to do. But in that case, again, the default we always go back to, if somebody else is sort of establishing a policy and that's what we have to do, is discussing what we understand to be the standard of care, insulin or metformin. Discussing how our patient was managed. Well, she got glyburide. And then in the middle, what was it about this particular case or our management that led for us being managing the patient differently than the guidelines? And in there, we will discuss in the all this week in the examination how to discuss issues in which we have other partners, maybe senior partners in the practice, especially consultants who are leading or sort of by policy having us do things that we may not be comfortable with, and how to do that without criticizing or dinging the person who is involved, but discussing it in a neutral way. And it is actually very easy to do, but there is really very little that is not defensible in the exam, even in situations like that. If you are using metformin, do just know the dosage you usually do. We usually do start at 500 and then we work up to 750 or 1,000 a day or so. You do not need to really know that unless you're actually managing someone on metformin in your pregnancy. If it comes up in a structured case question, you can just say, usually starts around 100, and I'd have to look it up from there, and that would be really okay. But do know your insulins because we are all using those. So again, insulin preferred treatment, we do have to watch for both hyperglycemia and hypoglycemia. So that's why the diet and patient comfort is actually very important. These patients do, when we have pre-gestational diet, glycemia, so we're talking about CAS B or C or 2, increased risk for preeclampsia. And remember that they do need a detailed anatomy evaluation, and they really should have a cardiac fetal echo in pregnancy, because 1% to 2% of all of us have some minor cardiac anomaly. And the risk of these organogenesis anomalies is increased 5 to 10-fold in people who are diabetic. So now we're talking maybe 5 to 10% of pre-gestational diabetic women may actually have a baby who has at least a mild congenital cardiac defect, and they may have something else. The neural tube defects increase 5 to 10-fold as well. So that is diabetes. Again, as far as when to deliver, current recommendations for people who are well controlled is at 39 to 40 weeks. You can actually do at 38 to 39 weeks, depending on the level of control and whether they're pre-gestational and anything else. So for your patients, just be sure to assess sort of the status of their diabetic management, whether they're gestational or pre-gestational, really important. And then just go by the ACOG guidelines in the practice bulletin on delivery, medically indicated delivery of preterm pregnancies, and just follow those recommendations. Now, on to cardiac disease in pregnancy. So this is the practice bulletin from 2019 is really good reading. We're going to cover in here some very specific things that tend to turn up commonly in the exam, but the important thing is that actually undiagnosed cardiac disease is actually a big cause of maternal death, and that goes along with myocardial infarction, sudden cardiac death, and development of cardiomyopathy. Those are the three things we're concerned about. So reading this before the exam is actually a really good idea. In this module, we're going to discuss some specific things about just management of people with cardiac disease in pregnancy and current recommendations. The important thing that I would want to mention in the exam, no matter what, is if I had a patient and for some reason I was concerned about her having underlying cardiac disease, a baseline brain natriuretic peptide, or BNP, is a good marker for risk of development of cardiomyopathy in particular. Do remember also, of course, if there's a history of maternal cardiac disease, we ought to think about fetal issues and vice versa. So in this module, we'll talk about these basic things. SBE prophylaxis, which is actually very easy these days. The New York Heart Association classification, which seems to turn up in here and there. The specific issue of mitral stenosis, which is a risk for intrapartium cardiac failure, and how to manage these patients. And then what are the high risk and sort of the not concerning risk patients as far as cardiac disease in pregnancy. And that's what we need for the generalist exam. So for endocarditis prophylaxis, it used to be that people who had mitral valve prolapse would actually be getting antibiotic prophylaxis in obstetrics for labor and delivery. They pared it down here for patients who actually require prophylaxis because they are fairly high risk, and it is only three things right here. If they have cyanotic cardiac disease, so this is a VSD, ASD, tetralogy of flow, something where they actually have a right to left shunt. So now we're talking about Eisenmenger syndrome or pulmonary hypertension. Those are the really high-risk people. If they have any kind of prosthetic valve, it does not matter whether it's protein or some other native material or whether it's mechanical. And if they have previously had bacterial endocarditis, these days it is uncommon for us to meet people in that category. But any of these three automatically qualify for an uncomplicated vaginal delivery for antibiotic prophylaxis. And otherwise, there is no specific recommendation for any of the minor valvular disorders. And for people who actually had appropriately corrected congenital disease, ASTs, VSDs, tetralogies, things like that. So if you need to know it, and this is just for reference, if you have to discuss it in the exam, this is the standard endocarditis prophylaxis, amoxicillin or ampicillin, amoxicillin PO, ampicillin IV. For penicillin allergic, we usually go through the same thing. We go through the second, third generation cephalosporins, clindamycin, vancomycin if absolutely necessary. The New York Heart Association classifications, we should know this. Class 1 is just like most of us, we can walk around without any difficulty, no dyspnea or chest pain. Class 2, mild symptoms means that maybe if we walked a couple blocks, we might actually start to get a little bit out of breath, or we might feel a little bit uncomfortable. Class 3 is we probably can't walk down to the end of the corner or get out and walk around the yard a couple of times without having some some cardiac symptoms, and class 4 is symptomatic arrest, and it's about as simple as that. Now, mitral stenosis, this does turn up here and there in the exam because this is something which is out there in the population, and knowing about intrapartum management is actually very, very important. So the issue with mitral stenosis is that because we have a stenotic valve, we have a fixed cardiac output coming from the pulmonary circulation into from the left atrium into the ventricle. And the problem with this in pregnancy is that the cardiac cycle obviously is divided into systole and diastole. Systole is always the fixed part of the cycle. It's about 10% of the cardiac cycle, and diastole is the rest of it. Normal physiologic cardiac changes in pregnancy is that the blood volume goes up. Obviously, at full-term pregnancy, we may be dealing with 50% more blood volume than prior to pregnancy. And the heart rate increases also. And that means that the cardiac output in liters per minute has to increase because of a higher blood volume, and we use a higher heart rate to pump it around. In people with mitral stenosis, the problem is that the systolic ejection part from the ventricle is fixed. And so the diastole is where we have to get this increased blood into the ventricle. And if the heart rate goes up, it means that the diastole is shorter. So we have to get more blood from atrium into ventricle in a shorter amount of time. And this is where we can actually develop a backup and pulmonary hypertension in pregnancy, and this can lead to congestive heart failure in labor, as we'll see, especially in the second stage of labor. So in addition to managing this carefully with a cardiologist, beta blocker therapy to lower the heart rate allows diastole to expand in time so that we can more likely get this increased blood volume into the ventricle by keeping the heart rate lower and have more time for it to be passed out in the situation, given that there's a fixed outlet and it takes a little longer to get more blood into the ventricle when the valve is fixed and stenotic. So how do we manage these patients then in labor and delivery? We do want to be careful with IV fluids. Regional anesthesia is definitely the preferred way to go, and vaginal delivery, if at all possible. This is one of those indications for maybe shortening the second stage of labor with an operative vaginal delivery, and also just letting the patient labor down so that Valsalvating and pushing is minimized at this time. The exception, obviously, is Marfan syndrome, but you don't necessarily have to know that unless you have somebody on your case list with Marfan syndrome. Supplemental oxygen is actually useful in this particular instance. We do want to keep the patient sort of head up and feet down just to avoid dependent return shunting of blood. And the important thing to remember here is that the third stage of labor is where they can suffer acute congestive cardiac compromise because the placenta is delivered, the uterus contracts, and a large amount of volume of blood in the gravid uterus is now shunted back into the central circulation as the uterus contracts very quickly, and that passes up into the heart, and there is a sudden load on blood passing through the venous circulation into the pulmonary circulation and then back into the heart again, and that's where they can compromise. Finally, what are the conditions with highest risk in pregnancy? Obviously, pulmonary hypertension or Eisenmenger syndrome. These are the people who have a left to right shunt through a defect. They have upwards toward 50% mortality risk in pregnancy. They really should not particularly become pregnant. Severe cardiomyopathy, very close to the same. Aortic stenosis with a less than 1 square centimeter, really tight stenotic aortic valves as well. Marfan syndrome because of the risk of dissection of the aortic root. And remember, class 4 heart disease is symptomatic at risk, but class 3 is pretty high risk as well. Anyone who has actually had testing and has been found to have an ejection fraction of less than 30% is at extremely high risk of cardiac compromise and actually of myocardial infarction or sudden cardiac death during pregnancy. So these are generally patients who should be counseled not to become pregnant. And if they are, they should be managed in a very high risk center with capable cardiologists and maternal fetal medicine specialists. What are the conditions for what we're not worried anymore? Anyone who's had a correction of a defect which could lead to cyanotic heart disease, and that's ASDs, VSDs, tetralogies that have been corrected and things like that. Also, most of us who have a minor ASD or VSD don't have a right to left shunt. We actually are functionally pretty good, and that's low risk as well. Most of the minor valvular disorders, again, mitral valve prolapse or regurgitation, tricuspid regurgitation or prolapse, no particular issue for pregnancy. Most people are asymptomatic. Now, onto thyroid disease in pregnancy. I think the important thing here on this slide, there are a couple important things that you might want to bring up in the exam about sort of how the changes in pregnancy lead to increase in protein, thyroid binding globulin, thyroid binding globulin. So we get increases in total T3 and total T4, and our levels actually, because there's more binding, can be decreased a little bit, but they're usually unchanged. The important thing I do want you to write on your slides here, and this is true for hypothyroidism and hyperthyroidism, which is coming up in the next slide, is that these exist in two forms, which is clinical and subclinical. Now, clinical is people who actually have overt symptoms of hypothyroidism or hyperthyroidism, and that brings them to medical attention, and they actually may have treatment. They may have actually for Graves' disease, they might have a thyroid ablation. They will go on medication. And these are the people for which we do need to be concerned about fetal effects as well as maternal effects, as if they're actually not regulated at the time they come into the pregnancy. Unrated hypothyroidism actually can lead to what they used to call cretinism and things like that. So clinical hyperthyroidism or hypothyroidism is actually a problem to be managed in the pregnancy. Most of our patients have subclinical hypothyroidism or sometimes hyperthyroidism, which is that they're picked up on the basis of laboratory values, but they clinically do not have symptoms, or absence of overt symptoms. And they should be managed and they're usually simple to manage. And in a generalist practice, we usually do very well with this. The TSH is actually what we should follow, and that should be done at least once every trimester or a little bit more often in people who actually are in good, stable medical management. Sooner, more often if we're actually adjusting management, and we may be doing that with an endocrinologist during pregnancy. But the important thing is do distinguish on your case list your patients who have clinical thyroid disease versus subclinical. The clinical ones are the ones who probably require more treatment with the specialist, and they may actually have the fetal effects. Then hyperthyroidism. This is Graves' disease in most all cases. When it's subclinical, it usually does not need to be treated. The reason for this is that the general recommendations these days is for people who have thyroid disorders, we'd like to have their thyroid status sort of normal to a little bit hyperthyroid in pregnancy. That tends to protect from unwanted fetal effects of being a little bit low. So running a little bit high is not a bad idea. And most people who have subclinical hyperthyroidism, we have that. People who actually do have overt Graves' disease need to be managed clinically and with an endocrinologist or maternal fetal medicine specialist. Now, over the past many years, I think it was 2009 that this article came out in the New England Journal of Medicine, they have been looking at what to use to treat people with hyperthyroidism in pregnancy for suppression. And the question is methimazole versus PTU. Methimazole is, of course, associated with a methimazole first trimester embryopathy, which can be fairly serious, although it's actually not very common. And so we tried to avoid that by just using PTU during pregnancy and not using methimazole. And then some information came up on people who in childhood were actually treated with PTU and who went on to develop hepatic failure and actually needed liver transplants in some instances. And there was a direct correlation between apparently the childhood use of PTU. And so people started thinking, well, what are the fetal effects of PTU in pregnancy? Could it lead to a similar thing? And there was a thought process that developed about using PTU just in the first trimester to avoid methimazole embryopathy, and then switching over to methimazole in the second and third trimesters to avoid prolonged experience to PTU. This has been sort of the party line for the past several years. It is now starting to swing back toward that the issue with hepatotoxicity is probably extremely rare, and it is fine to use PTU throughout pregnancy. If you just want to stabilize your patient on one agent, it is probably okay to do throughout pregnancy. Then on the next slide, we'll need to talk briefly about thyrotoxicosis or thyroid storm. And this turns up just in structured cases somewhere. This is unregulated hyperthyroidism in pregnancy, and it presents as a very hyperdynamic state. Fast heart rate, fast respiratory rate, fever, vomiting and diarrhea just from sort of gut hypermotility and usually dehydration as well, cardiac arrhythmias, and sometimes altered mental status. And this is an emergency. They're taken in through the ER and they're brought into the ICU, and this is emergency management. So we would be managing this with an intensivist specialist. And the idea is to regulate the thyroid quickly, and that's simply by giving a loading dose of PTU and Lugol iodide drops. And again, you just have to know that PTU and Lugol's iodide are in there. You don't need to know the dosages. You would have somebody else helping you in the exam. That's actually not important. We use stress dose steroids to mitigate some of the hyperdynamic effects. Dexamethasone is usually what's used. We can bring the heart rate down with beta blockers, and sometimes we'll need to use sedatives as well. And it's perfectly fine to use benzodiazepines. So for this sort of unregulated hyperdynamic hyperthyroid state, the idea is to control the thyroid quickly, PTU and Lugol's iodide, stress dose steroids, beta blockers to reduce the heart rate, and sedatives or benzos as needed. And that would really be the extent of what you would need to know, that it is a medical emergency. The patient is at risk and needs to be managed immediately in an intensive care setting, and these are the basic steps. Now, on to seizure disorders in pregnancy. It is likely that not many of us have people on our case list with seizure disorders in pregnancy. It's a minority, but this does seem to come up fairly commonly in structured case questions. And it turns out that there are actually some very important considerations for people who have a seizure disorder in pregnancy, because it's not just about management of the seizure disorder. It does turn out that if you have a seizure disorder in pregnancy, regardless of whether it is very well managed or not, there is a significant increase in the risk of loss, fetal demise in pregnancy, term and preterm fetal demise, fetal growth restriction, premature delivery. Remember, almost everything is premature delivery. There is an increased risk of congenital malformations, particularly because a number of the medications actually may be folate antagonists. So we see neural tube defects and things like that. And there also is an increased risk of preeclampsia. Someone with a seizure disorder does need to have assessments for preeclampsia and monitoring throughout pregnancy. So the risk there is actually fairly close to people actually who have hypertension with superimposed preeclampsia. But these are all risks in someone who has a seizure disorder in pregnancy, even if it is very well managed. Also, as we mentioned, anticonvulsants do actually interfere with some vitamin and mineral metabolism, but folate in particular, which is probably part of the reason for the neural tube defects being increased. So we'd like to use medications that actually don't have an effect on folate, and lamictal or lamotrigine and levetiracetam are probably the preferred ones in pregnancy. Now, there's a very specific protocol which is coming up for recommendations for managing these things in pregnancy, and that's what we really are going to need to know if it comes up in a structured case. So we'll get to this in just a moment. If they ask you, recognize that the common early agents, the valproates, the trimethylidiones, actually these cause cardiac and craniofacial abnormalities and other things like that, and they're not good. Dilantin is fine, but there is the fetal hydantoin syndrome. I would just glance at this once or twice. I don't think it's important for the examination, but Dr. Shamroth has felt that we should keep this in here. So I would just glance at that once or twice. Since Dilantin is not much used these days for seizure management, I don't think that it would come up on our examination. We just have it filed way in the back if you want. Now, the important thing about seizure management in pregnancy as far as preventing the seizures is that medication management is difficult because there are two competing mechanisms of use as far as maintaining stable levels of these medications. One is that protein binding of these anti-seizure drugs really goes down in pregnancy, so the drug levels can be very highly supratherapeutic. But at the same time, because renal clearance of them is really increased, they can go subtherapeutic, and there can be sort of a volley back and forth between the two. So it's very important to have a neurologist helping with this. Frequent monitoring of drug levels is important. And it's usually recommended that we should try to do one agent therapy if at all possible. So our neurologist will monitor for us. We should do 3 levels, and they'll do it about every 4 to 6 weeks or 2, because there can be wide swings during pregnancy. Then as far as the overall discussion of the risk, remember prematurity, fetal demise or loss during the pregnancy, fetal growth restriction, preeclampsia, other things like that. If possible, it's best to try to get our patients well controlled and on a single medication before pregnancy. And then careful monitoring of drug levels. They should definitely have good dating, because we want to be sure at term pregnancy we know where they are if we need to assess them or deliver them. Increased folic acid, 4 milligrams per day is certainly appropriate. There's no downside to giving people lots of folic acid. Dr. Hilbosell has put here at the bottom of the slide that there's some discussion about, based on the type of medication, considering one or the other. But I think in the exam, it's fine just to give everybody 4 milligrams of folate a day. It never hurts. We do need to do increased screening for the neural tube defects. Even remember, if they are on high dose folate, that does not bring their risk of neural tube defects back down to normal. It just decreases it some. And risk of other anomalies. Monitoring for fetal growth, third trimester assessment with biophysical profiles and antenatal testing, and monitoring for preeclampsia surveillance as well. Okay. That is everything I believe that you could possibly need to know for the generalist exam if they bring up seizure disorders in pregnancy. Now, on to antiphospholipid antibioticism. This actually in the past several years has become more of an interesting topic because we've been able to recognize it and diagnose it, and we really have a very good understanding on the potential implications for a pregnancy in people who have this condition. So we would start at the beginning. The examiner would say, so Tell me about antiphospholipid antibody syndrome. When you say, well, it's a type of thrombophilia where we have an increased risk of blood clotting, and it can be one of the more severe blood clotting risks in someone throughout life. They can have DVTs or pulmonary emboli. And the examiner would next say, so tell me, what in your practice would concern you that a patient might have a syndrome like this? So here's where we go through the criteria. We need to have one clinical criterion and one laboratory criterion, and that's just a blood test. So the question is, who do we test? Because we don't routinely screen people for things like that, and what are the tests to do? So let's walk through that for just a moment. There is one thrombosis criterion and two pregnancy criterion, which we'll get to on the next slide. Anyone who comes into you for prenatal care and has had any type of vascular thrombosis should actually be tested for antiphospholipid antibody syndrome. Any DVT, PE, anything in the back. And this goes across the board. Back when I was in residency a long time ago, there actually was something that a thrombotic disorder that they called thrombophlebitis obliterans, which is where people would actually get arterial thrombi. I actually took care of a pregnant woman who had lost part of one arm from an arterial thrombus. These are the sort of people who can have antiphospholipid antibody syndrome, and it could be anywhere in their body. So anyone with a VTE event, automatically test them for APLS. So on your case list, if you have on your problem list history of DVT, the examiners are going to be really interested in sort of how you're managing with anticoagulation during pregnancy and how you're delivering them. They also want to be sure that you tested them for APLS. Pregnancy morbidity. So this is one or more losses at greater than 10 weeks gestation without obvious aneuploidy or anything else like this. And the important thing is that the loss occurred at 10 weeks. So this is not somebody that on a 10-week ultrasound, I couldn't feel the heartbeat. And I went back and did an ultrasound and it showed a 7-week fetus. That's probably a demise that occurred prior to 10 weeks. This is actually a demise at 10 weeks or more without identified aneuploidy or other issues on specific testing. Or 3 or more consecutive losses at under 10 weeks gestation, also without any obvious things going on that could otherwise explain the loss, such as a anatomic or maternal abnormality or aneuploidies or things like that. So 1 at 10 weeks or more, documented 10 weeks, or 3 or more at under 10 weeks, either one of those is a criterion to test for APLS. Or any pregnancy or preterm delivery which is due to severe preeclampsia. So not just regular preeclampsia, but preeclampsia, severe preeclampsia, eclampsia itself, or fetal growth restriction, which preterm is sort of a marker for undiagnosed preeclampsia. That is an independent risk factor as well. So any one of these 3, or someone who has had a clot prior to pregnancy, is an indication to test. Then in order to identify that they have APLS, we need to do a blood test. These days, the go-to is the anti-OB02 glycoprotein antibody. We usually do an IgG or an IgM. This is the most sensitive. Next to that, the lupus anticoagulant is also very good. If you live in a community or a situation where they can't do the beta-2 glycoprotein, that's actually very good. Anticardiolipins are very non-specific. They can be positive in people who have a wide spectrum of autoimmune disorders, and sometimes they're just there without being any marker for chronic disease. So beta-2 glycoprotein, if possible, lupus anticoagulant if you can't get the beta-2 glycoprotein. And these, for the blood test, you do actually have to get a positive on 2 or more occasions at least 12 weeks apart. So 1 turning up positive may make you suspect, but in order to actually diagnose, you have to have 2 at least 3 months apart. So then, suppose we have actually identified a patient does have APLS by clinical criteria and proven by blood testing. So then we have increased surveillance because they are at increased risk of thromboembolism during pregnancy. They are increased placental insufficiency, fetal growth restriction, induced fetal demise, prematurity, present in everything, remember. So we start from 20 weeks on after their anatomy ultrasound, careful surveillance for preeclampsia and also for risk of thrombosis. We'll talk about anticoagulation management on the next slide. We should start our fetal surveillance from 28 weeks, not 34 weeks as we usually do for common disorders, and particularly looking for fetal growth restriction. Now, how to do anticoagulation if they have not had a previous clot and we just diagnosed them based on the pregnancy criteria and the lab tests, then you have the option of anticoagulating them or not based on history, shared decision-making, other things like that. But if they have had a previous history of thrombosis and that was your clinical criterion, they should be anticoagulated with heparin or with enoxaparin, Lovenox throughout pregnancy, in addition to your low-dose aspirin. Then delivery recommendations based on your findings of screening. term if no other complications turn up, anticoagulation for at least 6 weeks postpartum. These people actually have a fairly high level thrombophilia. This is more serious than even a Leiden factor 5, so they should never be given estrogen-containing contraceptives or medications, and they should actually be managed long-term by a hematologist. APLS really requires lifelong management. There's a high risk of thrombosis. They should be managed by someone who's a specialist. This actually has been all gone over in the Joanne section. Now, fetal growth restriction. There are a couple important things in here. The ECOG Practice Bulletin 227 is a really good read, and in there they referenced the Society for Maternal Fetal Medicine clinical consensus on this from 2020, and I'm going to give you some of both of that just to jot down a couple notes in the end on slide 115, which is coming up in just a little bit. So remember, these days, fetal growth restriction is a antepartum diagnosis. Antepartum, based on usually ultrasound assessments. We have low fundal heights, we get an ultrasound. Our estimated fetal weight is 10th percentile or below, or independently, the abdominal circumference itself is 10th percentile or less. That's clinical diagnosis of fetal growth restriction. Remember that SGA, small for gestational age, is a postpartum diagnosis, just like LGA. SGA is my baby is born. I weigh the baby. The weight is actually at the 10th percentile or less for the gestational age in weeks as a reference at which that baby was born, 10th percentile or less, then that's SGA. IUGR or FGR is antepartum. SGA is always postpartum. Do remember that when you're going through your case list, and just be sure in the exam you're using the correct terminology for that. Now, the examiner's next question is, and we'll do this in one of our mock orals and webinars, actually. So what's your diagnosis? If the baby has an estimated fetal weight under 10th percentile, is that IUGR? Well, is it? The answer is no, because there's actually 3 things in the differential diagnosis. The first is that this is fetal growth restriction, and that's the one you really want to not miss and pick up on. The second is that this could be a dating error. If we don't have our dating quite right and we're reading the estimated fetal weight for a pregnancy is less far along than we think it is, it's far along than we think it is, we actually could have an estimated fetal weight that is off by that. The third one is that this could be what we call a constitutionally small fetus, because remember that 10% of all fetuses will have an estimated fetal weight in the 10th percentile or less. That's just how statistics work. But not all of them are fetal growth restriction, and only a few of them are dating error. So then the question is, so doctor, how do you tell the difference between the constitutionally small fetus and the growth restricted fetus, or do you even need to? And the answer is, of course, yes, you do, because the constitutionally small fetus is normal, just a little small. And the growth restricted fetus is because of some underlying maternal, fetal, or placental condition and is at high risk of progressive IUGR and of fetal demise, which is constitutionally small fetal is not. So how do we tell the difference between a constitutionally small fetus and a FGR fetus? Well, the constitutionally small fetus will stay on the same part of the growth curve. It'll be 10th percentile all the way up until delivery and will probably be born at the 10th percentile. The growth restricted fetus will fall progressively off the curve. It will go 10th percentile, 8th percentile, 7th percentile, 5th percentile, or worse as you get toward delivery. What's the other way to tell? In the live course, I would just wait for somebody to answer, but the other important distinction is symmetric versus asymmetric indices. So the constitutionally small fetus would be symmetric. It would be 10th percentile, but all of its indices would be 10th percentile. The growth restricted fetus can be symmetric or asymmetric. Symmetric IUGR is usually from something earlier in pregnancy. It's usually a fetal or early maternal issue. Asymmetric IUGR is what we see, or FGR is what we see maybe late second into third trimester. And that is where there is head sparing. So the head circumference might be 11th percentile and the abdominal circumference might be the 5th percentile. And that is asymmetric IUGR, and that is not consistent with the constitutionally small fetus. So there's our differential diagnosis laid out right there. Then the examiner would ask you, so what are the causes of fetal growth restriction? Always think maternal, fetal, placental, anytime we're asked for underlying causes or risks in the exam. And that works very well. And if you can name perhaps 2 of each, that gets you 6 right there. And remember, the exam pro rule is 5 plus or minus 1, and you've gotten there. So this will have to do with underlying hypertensive diabetic orders. It may actually be a fetal aneuploidy or condition, infections in pregnancy, exposure to exogenous factors such as teratogens. There may have been trauma or injury during the condition. It may be tobacco, alcohol, substance use, which affects the placenta. It may be an inborn error. We may have a really bizarre abnormal placenta, like a circumvallate placenta or something like that. I think we've got a 5 or 6 right there. And then finally, so doctor, you've identified your fetus has fetal growth restriction. How are you going to manage your patient for the rest of the pregnancy? This, again, when you're looking at your case list, has very much to do with when you diagnose this disorder relative to the time when the pregnancy would normally be delivered. You may diagnose it at 38 weeks or so, where really it's just appropriate to induce labor and deliver. You may identify it at 33 to 34 weeks, at which point there is some time where you'd want to try to manage the pregnancy if possible if no serious issues arose. And that would have to do with antenatal surveillance, biophysical profiles and NSTs, usually Doppler velocimetry, looking at Doppler arterial flows and indices there, assessment of amniotic fluid index, careful surveillance, and perhaps delivery if any complicating factors came up which were abnormal for any of those, or cessation of fetal growth, that may be another one as well. And if not, you could go to term. So the examiners are very good when they're looking over your case list before they meet with you. Fetal growth restriction is one of their high yield topics. And they're actually looking at the details of, at what gestational age did your patient deliver? And then they're expecting to hear from you sort of how you managed based on whether it's just time to deliver or whether you had to do some antepartum management. And again, the other thing that I wanted to mention is, and please jot these down sort of around the end of this slide here, since we're at slide 114. This is from Practice Bulletin 227, and there are ACOG recommendations for delivery for complicated and uncomplicated IUGR. And then SFFM comes at it from a little different way. They actually look at the percentiles, 3rd percentile to 10th percentile, and they have some recommendations based on that, and they're quoted in the Practice Bulletin. So I think it's good to know both. So ACOG says for uncomplicated fetal growth restriction, deliver at 38 to 39 and 6, basically 38 to 40 weeks. And uncomplicated means you don't have oligohydramnios, you don't have abnormal Dopplers, and you don't have any other maternal comorbidities, which might argue for delivery, preeclampsia, something like that. So uncomplicated fetal growth restriction, 38 to 40, basically. Complicated, which is presence of oligohydramnios, abnormal Dopplers, maternal comorbidities, cessation of growth, any of the other red flags, 34 to 38, basically, 34 to 37 and 6, anywhere in there, depending on the particular situation. Now, the Society for Maternal Fetal Medicine, which is quoted in, this is their consult series number 52, if you just want to jot that down and go read it, from 2020. This a little bit differently. They said their delivery recommendations is if your estimated fetal weight is above, is 3rd percentile or above, 3 to 10%, that's considered uncomplicated, and you have normal Dopplers, deliver at 38 to 39. So it's not the 38 to 40 thing. If you have estimated fetal weight or AC that is under the 3rd percent, deliver by 37 weeks or earlier if diagnosed. So there's a little bit at odds in here, and they are both quoted in this practice bulletin. I would stick with the ACOG recommendations if you're asked about it in the exam, because that really is based on a present assessment of the complicated or uncomplicated variety, which is really direct fetal assessment status. The SMFM is coming at it indirectly from what the percentages are, but I would know that just and file it in the back of your mind. And if there are questions, I'll be happy to reiterate that when we come to our question section at the end. All right. Now, IUFD, very briefly, this was an excellent practice bulletin that came out in February 2020. How do we manage a 2nd or 3rd trimester fetal demise? The way it progresses here is sort of once we identify it, how do we manage a patient who now has a deceased fetus and needs to be delivered? So what do we consider as far as timing and mode of delivery? Next, what assessments could we do immediately at that time to try to identify any underlying causes of the term demise? And then how do we counsel our patient and discuss those results with her? And then the final thing is, in a subsequent pregnancy, what are the recommendations for managing someone who's had a previous 2nd or 3rd trimester fetal demise, regardless of whether we have identified why it happened, because in most of these cases, we don't identify a specific abnormality. And what are the recommendations for both screening and for evaluation and management during that next pregnancy? So first, we have an IFD at, let's say, 34 weeks. How do we manage it? Well, first of all, we can either induce or wait for spontaneous labor. Most of our patients usually would prefer to be induced, but the current recommendations are, depending on the gestational age, if we're under 24 weeks, we would prefer a D&E to doing medical induction of labor. If you're from 24 to 28 weeks, it's reasonable to do vaginal misoprostol. And if you're above 28 weeks, oxytocin with or without cervical ripening is appropriate. And this is what I would know for the exam. That was one of the important take-home points from this practice bulletin. Then we'll get into in just a moment what we should do as far as testing assessment on the next slide. Obviously, our patients require a lot of support and long-term support. So we do want to have us and their families and actually specialist counselors and other people assisting them with this. Now, what would the workup be? I've highlighted in here, and I believe I'm remembering this is a direct quote from this practice bullet. It said, a histologic assessment of the placenta is the most valuable test that can be performed following a fetal demise. So no matter what, always send the placenta to pathology, and that's where we get most of our information. Above that, starting from the top, we are looking back in the family and maternal medical history. Is it possible that this patient was an undiagnosed diabetic? Because that's fairly high on the list, and that's part of the testing after pregnancy, before the next pregnancy. Is there any family history of anything like this that we would want to know about? Is there anything going on that we were not aware of as far as exposures to things from the outside, drugs, medications, things like that? Anything from the past pregnancy history that we would need to know of? Is there any undiagnosed maternal disease? Then diabetes comes in there that we are not aware of that we need to work on. Evaluation of the fetus and placenta and cytogenetic analysis are the three things that we can do as far as testing. So fetal karyotype is actually perfectly appropriate. The placenta is the most important thing. Circle of that is the first thing we want to mention on the exam. This practice, well, it was suggested that recommending or requesting an autopsy of the fetus may be suggested, but families are sometimes resistant to that. And these days, it's considered that a post-mortem MRI of the fetus may be almost as valuable in identifying undiagnosed physical or congenital abnormalities, which may determine the cause as well. So we can discuss with our patients autopsy or a post-mortem MRI, which can be performed fairly shortly after delivery. Then, final question is, in the next pregnancy, how would we take care of our patient? This is obviously a very tense and anxiety-provoking situation in someone who's had a traumatic occurrence like that. So the fear in the subsequent pregnancy is fairly high. The recurrence risk, fortunately, is fairly low, regardless of whether we've determined what the cause was for this. But there are some specific recommendations from ICOG that I just want to go over. It is reasonable, they said, to perform ultrasound surveillance. So after our anatomy ultrasound, you can do actually ultrasounds as early as 24 to 28 weeks and on every 4 weeks or so. Kick counts are definitely reasonable. They've also suggested in here, and this is a new change in this practice book from 2020, because they used to really play down the idea of doing antenatal testing or fetal surveillance. They've said that it is reasonable to offer the patients antenatal surveillance, which would be biophysical profiles or NSTs, during the pregnancy, usually starting at a time which would be 4 weeks before the gestational age at which the IUFD occurred in the previous pregnancy and continuing on from there. So gestational age appropriate as to whether it's biophysical profiles or ultrasounds or Dopplers or other things like that, but it may be offered to the patients, and usually starting about 4 weeks before the date of the previous demise. Planned induction or delivery at 39 weeks. This again would be an elective induction, remember, not a medically indicated induction as well. And sooner if there are any obvious concerns that turned up on your antenatal testing. But I think the important take-home points here from that is that examination of the placenta is really, really important. And gross ultrasounds and antepartum testing are now okay with ACOG, and they may be very reassuring to our patients as well. Then moving on to thrombocytopenias. In this section, we will talk about gestational thrombocytopenia and then really just ITP. Preeclampsia we've sort of hit previously. And the differences here really in the thrombocytopenias that we're going to talk about here is with preeclampsia, low platelet count actually does involve usually abnormally functioning platelets, and that's where there's the increased bleeding risk. With gestational thrombocytopenia, ITP, and other related symptoms, the platelet count is low, but the platelets actually are fully functional. It's an antibody-mediated platelet destructive disorder, but the platelets function okay. So you can go down to a fairly low platelet count, 20 to 30,000, and actually not have a risk of significance during labor and delivery. And we'll talk separately about neonatal alloimmune thrombocytopenia, which is NATE, which is completely different. It is actually a alloimmunization phenomenon. So we'll hit that separately. So know just again the basics of platelet levels in pregnancy. Most of our patients would be above 150,000, sometimes 100 to 150. Again, in the absence of preeclampsia, not really worried unless we get a platelet count maybe below about 25 to 30,000 or so. Gestational thrombocytopenia, or what we call idiopathic thrombocytopenia, is the most common cause. And we'll see this here and there if we just happen to get platelets on our patients. For a non-complication patient coming in labor, usually we just get a hemoglobin hematocrit, type in screen, RPR, toxicology screen, things like that. We don't necessarily check platelets on everybody, but if we do, we may see a low count. It may be 5 to 10% of pregnant women, depending on our population. These are not of any clinical significance. The platelets go down, they come back fairly quickly after delivery. It's usually seen right around the time of delivery. And you just check them, and they'll usually come down and come back up, and you can just observe them in the next few weeks of postpartum. So if it occurs without any other symptoms of a hypertensive disorder pregnancy like preeclampsia or any known history of an autoimmune platelet disorder, it generally doesn't require any concern or surveillance on our part. ITP is different. This is actually antiplatelet antibodies. So levels can be variable, but they can be sometimes low. And this is in people who can have a variety of other autoimmune diseases, lupus-related diseases as well. It is important, and I'm glad we put this at the bottom of the slide. TTP is a very different thing. TTP is what we call hemolytic uremic syndrome. And this is actually a renal disease. Thrombocytopenia is part of it, but it's actually a very serious hepatorenal disease with a hemolytic anemia. So we're talking now about not just platelets, but destruction of red blood cells. Totally different thing. When we're talking about thrombocytopenia, we're really looking at ITP. Platelet levels can go fairly low, but again, the platelets are functional. So if for managing patients in labor and delivery and having your anesthesiologist comfortable with an epidural, you would like to raise the platelet count, giving steroids is a very easy way of doing it. If that doesn't really work and you want to, in advance, plan to get the platelet levels up, there's an IV immune globulin that can be given once. Your hematologist can help you with this. And actually it's very effective as well. It would be extraordinarily unusual to have someone with a critically low platelet count who required a splenectomy in pregnancy. I've actually never heard of or met anybody who required that. That would be very extreme. But the idea is, if you want to keep your platelets at a level where your anesthesiologist is comfortable, but if you're above 30,000, there's no risk to the patient. And although these antibodies do cross the placenta, we are not concerned about fetal thrombocytopenia issues at all, really at all. So steroids or IV immune globulin. So again, just reiterating, it is extremely rare in people with ITP to have any fetal assessment. So you do not have to actually do any fetal testing. You certainly don't do pubs and look at the fetal platelet counts as well. Then NATE, or neonatal alloimmune thrombocytopenia. Now this is actually the platelet version of RH isoimmunization. So with RH, we have someone who is homozygous recessive for the CD, or usually the D antigen. So she is RH negative. And if the partner or father of the pregnancy is Rh positive, then she will be exposed to the D antigen and will develop an antibody response, which in a subsequent pregnancy actually can cause destruction of fetal red blood cells, because these antibodies cross the placenta and can lead to fetal hydrops and fetal death. This is the platelet analog. These are people who are homozygous recessive for one of these 15 platelet-associated antigens. Usually HPA1 is the most common. And they would not have any knowledge of this at all. And the father of the pregnancy actually, like most people, probably has one of these antigens. And so they can actually develop a platelet antibody reaction, which actually in this pregnancy, as well as in a subsequent pregnancy, can cross the placenta and cause a very severe fetal thrombocytopenia. And this is where we can actually get intracranial bleeds or fetal bleeding issues. And this is sometimes a cause of loss of pregnancy. So these would be managed by, at delivery, sending usually the maternal blood and partner's blood. Often there are now a number of laboratories actually can test for these antigens, and you can identify that. It is not something like RH isoimmunization. Once it's happened, it actually cannot be treated. There is now an ongoing risk for the pregnancy. But the idea is just for us to understand what this is. And if we have a baby who is delivered who is very severely compromised by a bleeding disorder, this is one of the things that we should think of. Then into multiple gestation, and we are actually doing very nicely here. We are ahead of schedule, so we can take a few deep breaths and relax here. Multiple gestation is actually a fairly common topic in the exam these days. So we'll walk through this. Most of us on our case list have twins, and probably have di twins, or maybe a mono-di twin. Mono, pretty uncommon unless we're in a maternal fetal medicine era. Conjoined twins, almost never. And triplets and more, really, with the MFM people. So this again is about how do we identify a multifetal gestation? What is our understanding of the risks of a twin pregnancy as opposed to a singleton pregnancy, and how do we assess for those risks and look at them depending on the type of twin or multifetal pregnancy? And then how do we manage our patients throughout pregnancy? And then how and when would we deliver them? So we'll walk through each one of those. These are just basic good stats, I think, these days, of the incidence of twins in the general population without assisted reproductive technologies. Also, remember that twinning exists in a number of forms, and about every 4 days post-fertilization, we move from a less to more of a coalescence of the twin. So really, if we're very early, and this is something that happens at or in a day or so post-fertilization, the twinning will result in diamniotic dichorionic. So we have 2 placentas, 2 amniotic sacs. And then about 4 days to 8 days out, then we go to dimono, where we actually have 1 placenta and 2 sacs. More of a concern now because the twins are sharing a placenta. And then when you get to about the next 4 days out, 9 to 12, then we're down to mono, which is 1 sac, 1 placenta, extremely high risk. And then at about 2 weeks out, we get to conjoined twins. So first of all, doctor, how do you identify a twin gestation? Well, in my practice, at 6 to 7 weeks, we always do an early OB ultrasound on our new registrants, and we're looking for, doctor, what do you look for in that ultrasound? I look for, first of all, is there a pregnancy in the uterus? You always want to start with the really simple stuff when you're talking to the examiners. It seems stupid and pedantic, but yes, is a pregnancy in the uterus? Can we identify it, or is it an uncertain location, or is it ectopic? Next, can I identify that it is viable? Do I actually have a fetal heartbeat? Third, what is the gestational age? Does it line up reasonably well with menstrual dating and other criteria? And finally, is there more than one fetus present in the pregnancy? And then they say, well, so you have a twin pregnancy, what do you do next? What are your concerns? And my next question would be, well, twins exist in a number of forms. They can be mono, mono. It's important for us to assess as early as possible what that is, because there's a different level of risk for each one. Oh, doctor, well, how do you do that? Well, here's the important thing. Chorionicity and amnionicity cannot really be determined on a 6 to 7 week ultrasound. 9 to 10 weeks in most practices is a reasonable sign at which you can see the lambda peak sign, or you can actually see the 2 separated placentas and the 2 separated sacs. So we can't at 6 or 7 weeks get to that. We have to wait out until about 9 to 10 weeks to determine that. And then we determine our pregnancy management based on that. So again, the more we tend toward monochorionicity, the more the risks go up. If there's a shared placenta or a shared placenta and a shared sac, there are a higher risk of twins being compromised. And remember, in these mono-di or mono pregnancies, as we'll talk about, there is no normal twin. Each of them are actually at risk. If one is at the losing end of a placental steal or twin-twin transfusion, becomes growth restricted, the other one can become hydropic. And in a mono pregnancy, both of them are at very high risk of loss through the pregnancy. So again, always, what are the risks of twin pregnancy? Prematurity, increased risk of congenital anomalies because you have more than one fetus in there. It's not twice the risk, but it's increased. Growth disorders throughout the pregnancy as well. We'll talk about fetal growth restriction, loss of one twin, and some other things. So then how do we manage it? The basics are in pregnancy that we discuss the type of twinning as soon as we can and the risks with our patient and their management. Remember, multiple gestation is a low-dose aspirin indication. Want to have a little bit higher, maybe more caloric intake during pregnancy. Good screening for aneuploidy and anomaly testing, because we have 2 babies in there. The risk that one of them or in the pregnancy would be affected is higher than if you had a singleton pregnancy. And remember, your AFP cutoff is a little bit higher. And then what do we do with antepartum testing and delivery timing? Let's see, I'm going to go to this real quickly, just a second. Let's go back for just a second. Sorry about that. Right back to this here, good. So management. Ultrasounds, and again, chorionicity, diet, low-dose aspirin for antepartum testing. Growth ultrasounds about every 4 weeks are considered reasonable and appropriate here. Now, ACOG has sort of slid around on this for a while, but I'm going to quote from what we have in the most recent practice bulletin here on twinning from 2021. It says, quote, no evidence-based recommendations for frequency of growth ultrasounds exist after 20 weeks of EGA, which is your anatomy ultrasound. However, it seems reasonable to perform growth ultrasound every 4 weeks in the absence of evidence of IUGR or other pregnancy complications, which means it is appropriate for us starting at 24 weeks, 4 weeks after our anatomy ultrasound, to do growth ultrasounds every 4 weeks. For antepartum testing for uncomplicated di-di twin pregnancies, there is no recommendation for biophysical profile testing NSTs. However, the most recent practice bulletin from 2021 says it may be reasonable to perform antenatal testing starting at 36 weeks, which basically means 2 weeks before delivery, because we deliver di-di twins at 38 weeks of pregnancy, and that's only for di-di twins. Mono-di requires more testing, of course. Delivery timing for uncomplicated di-di twins, 38 weeks of gestation. Mono-di, 34 to up to 38. Mono-mono, 32 to 34 are the most common ones. And delivery mode, as per your preference, one twin at least being in cephalic orientation is reasonable for a trial of vaginal delivery. If the two twins are in presentations for which it's not appropriate breech transfers, we would go with cesarean. And that is according, again, to the standards of your practice and your personal mode of practice and what your hospital and your department prescribe for you. Then maternal complications, all of the above on this list, just higher for all the complications of pregnancy because there are 2 fetuses in there and there's a higher risk for the pregnancy because that. Hypertensive disorders of pregnancy, remember we are looking for blood pressure issues and we're looking for preeclampsia spectrum disorders, diabetes. I think multiprenatal gestation is an indication for early GTT testing as well. And of course, common intrapartum complications. These are just reviews of things that we already know. Move on to one more page of notes here. I didn't want to let you guys know about this. So there are some stats that came out of that 2021 practice bulletin. IUGR with deaths of a single twin, IUGR is 5 times the risk of a singleton pregnancy. I've just put that in there as well. Twin reduction can occur in up to 1/3 of cases. Congenital anomalies, usually cardiac, are actually 2 times the risk of a singleton pregnancy. We have 2 babies in there. And they are usually cardiac or neural tube or GI issues like colonic stenosis, DFISH, or other stuff like that. Twin transfusion, again, the important thing about these mono to monodi pregnancies is remember that there is no normal fetus of any sort in these pregnancies. One may be at risk of fetal growth restriction and death from that. The other may be at risk of congenital heart failure and hydrops from overperfusion. And so that the surveillance for this, since these things can develop at 18 to 2 weeks of gestation, occurs much earlier. Mid-trimester diagnosis, mid-trimester onset of testing, which is usually the ultrasounds with monitoring Dopplers, and there usually be middle cerebral artery Dopplers in the mid-trimester of pregnancy if you have a monodi pregnancy on your case list. Good. So that, I think, is everything I needed to say about twin pregnancies. So let's go on to preterm labor. There's one really important thing that I do want to talk about preterm labor because it comes up all the time in the exam, and that is our use and management of tocolysis. And the standards for this have really changed in the past 10, 15 years or so. So I'm going to talk about this. This slide we have in here just as a reminder, sort of know the basic weights, birth weights at every 4 weeks in pregnancy or so. No, this is another little bit of homework. Be sure to know your NICU stats. So based on the gestational age of delivery, what is the expected survival of a infant in your hospital system? And what is the survival with and without complications? And just know some rough percentages. The examiners will just sometimes throw that out there. And if you actually don't know what goes on in your own hospital, it feels kind of uncomfortable. So do be sure that you just know the up-to-date stats just very roughly, and that would be perfectly fine. Now, the issue with preterm labor is first of all, when do we do steroids and when do we do tocolysis? So remember now that steroids have been moved down to about 23 to just shy of 36 to 37 weeks of gestation. And the most recent update said you can consider them at 22 to 23 weeks if the family is electing neonatal resuscitation. So it can be actually now 22 to 23 up to 36 and 6. Remember, we give one course, we repeat it in 7 to 14 days from the first course if we expect delivery within 7 days and if we are under 34 weeks of gestation. We've talked about fetal fibronectin before. Remember, that really is a value for the negative predictive aspect. So a negative value is fairly predictive that there will not be a preterm delivery within the next 7 to 10 days or so. Positive predictive value is very low. In the past 6 weeks, I've had 2 patients come in with preterm contractions. Both of them had positive fetal fibronectins. They are both still pregnant. Now, this is important. Let's do tocolysis just next. So this is something to write down on your slide here. They will ask you, so doctor, with a patient with preterm labor, how do you manage tocolysis in your practice? So there's no longer any specific indications for universal tocolysis in someone who has preterm labor. But over the long term, there is use of tocolysis very short term, 24 to 48 hours. And there are 3 specific conditions that I'd like you to keep in mind if they ask you, and these are the appropriate indications for tocolysis these days. And it is really just to provide some time to sort of optimize status prior to an anticipated delivery. But long-term tocolysis is no longer recommended. So please write these down. The first is we would use tocolysis maybe 24 to 48 hours for someone who's in active preterm labor to provide some time to optimize the fetal status for delivery. So if I have a patient maybe is at 29 weeks of pregnancy, I would want to get the betamethasone course in. I would like to do magnesium for neuroprotection. And I would like to delay delivery for enough time to get into that, which significantly improves the fetal outcome status. And that's the first appropriate indication for use of short-term tocolysis. Optimizing the fetal status for an anticipated, seriously, preterm delivery, especially steroids, neuromag, or just steroids. The second is, I don't know why the preterm labor is occurring, but short-term tocolysis can actually buy us some time to treat an underlying maternal condition, which if it were resolving, might actually resolve the preterm labor. I think a really good example of this is an active pyelonephritis, which could trigger preterm labor very easily. If I can take 48 hours of antibiotics to calm down the pyelo, it is likely that I can get the preterm labor to resolve and the pregnancy may continue for some time. And there are a number of other instances, perhaps a sickle cell anemia crisis. I think we can name a fair number of them. But underlying maternal conditions, which if treated and resolved, might allow the pregnancy to continue is an important reason for short-term tocolysis. And the third one, which depends on where we practice, is to delay delivery to allow some time for transport to a higher level of care facility, either for fetal care like a higher level NICU or for maternal care if there's a maternal comorbidity. And short-term tocolysis, as long as both mother and fetus are stable for transport, and that's important, would be our third indication. Now, we have to talk about cervical shortening, interclauds, and cervical insufficiency. So this is the update from April, which is after our slides were finalized. So this is an additional slide that I put in here. Please take a picture of it, save it for your collection. This is really important for the exam this year. So as you know, on April 6th, the FDA withdrew the approval of Makena, which is 17-hydroxyprogesterone injectable for treatment of women with a history of prior spontaneous birth. And ACOG, I think within 2 days, came out with its practice advisory, which updated the recent practice bulletin. And here's what ACOG says on it. We don't use 17-hydroxyprogesterone anymore for the primary prevention of preterm birth in a history of spontaneous preterm birth. So what that meant is, we can't get it anymore anyway, that in people who had a prior spontaneous preterm birth, we would offer them weekly 17-hydroxyprogesterone from 16 weeks on. That's no longer appropriate. In addition, here's what ACOG said is we don't use vaginal progesterone either as a primary prevention. So in patients who have had a previous spontaneous preterm birth but are doing well in this pregnancy, we don't automatically offer them vaginal progesterone in place of the injective progesterone. We use vaginal progesterone now in one specific instance, and I've listed it right here. A woman has had a history of a spontaneous preterm birth, and she has a singleton pregnancy, not a twin pregnancy, and she has shortening cervix as identified by ultrasound. And we'll talk on the next slide about the standard criteria for when to do vaginal progesterone in people with shortened cervix and when to do cerclage in people with shortened cervix. But the important thing is there is no progesterone injection, dual or oral these days, which is going to be used as a primary prophylactic or preventive in someone who has a previous spontaneous preterm birth. But at this pregnancy, no evidence of an impending risk of preterm birth, such as a shortened cervix. So I've aligned out here, please on your slide, line these out because these are, since April, these are no longer valid, but they're on the slides because the slides are from March. So just do a big line through what I've lined there. So how do we assess in people with previous spontaneous preterm birth? How do we sort of manage surveillance? First of all, for people who have not had a previous spontaneous preterm birth, that's the low-risk patients, you just do the cervical length at your 18 to 20 week ultrasound. And if it turns up less than 25 millimeters and you're still before 24 weeks, then that's a shortened cervix. Then you can offer them vaginal progesterone. For people who have had a previous spontaneous preterm birth, this is the general obstetrical population right here. Now these are the people with the previous spontaneous preterm birth. We do the cervical length screening every 2 weeks is reasonable from 16 to 24 weeks. And if you pick up a cervical length at less than 25 millimeters, you would offer them progesterone, which is why I've highlighted it right there. And then you would do a cerclage in someone who has actually had a rescue or exam indicated cerclage for a very high-risk situation like a dilation of the cervix, or an ultrasound indicated cerclage in someone who had not been offered progesterone but was having significant cervical shortening. So the important thing these days is that we do the screening every 2 weeks. First step is to offer vaginal progesterone if they have a previous spontaneous preterm birth and a shortened cervix, and then cerclage is the next step up from there. Remember that in twins, this is really the only reason it's up there, we don't do cerclages in twins. We don't do prophylactic cerclage in twins, and there's no evidence that progesterone is we don't do prophylactic cerclage. Vaginal progesterone is not indicated to be a benefit. We can do a rescue or exam indicated cerclage. And please line out on the bottom of the slide again the bit about 17-hydroxyprogesterone. Finally, this is just a reference slide, just because we talked about neuroprotection for preterm labor. Just know in your institution what's the protocol for doing magnesium sulfate, the dose, and the time to just be able to discuss that with the examiners. And finally, post-term pregnancy. And I think we're going to go to a break in a few minutes, and we're nicely ahead here. The one thing I wanted to mention here is, and this comes up every year, post-term pregnancy is a category on our case list. And it is surprising how often we do read case lists in which our candidates have put a pregnancy that is 41 weeks and some days in the post-term pregnancy category. But remember, the definition of post-term category is 42 weeks or greater gestation. Now, you may be someone who already has some 40 to 41 weeks, probably 41 week gestations in your post-term pregnancy category, and that is not a problem. What you want to do is recognize it right now, which is why we really are emphasizing pre-vetting your case list and going through this and identifying those cases, so that in the exam, when the examiner says, I see here that under post-term pregnancy, you had someone who was 41 weeks and 2 days. Tell me, what's the definition of post-term pregnancy? You're going to tell them, well, it's 42 weeks of gestation. I recognize that this patient is 41 weeks of gestation, but she's in her 42nd week, and I didn't have people over 42 weeks. And I thought it would be interesting to have a patient in here so that maybe I could discuss, if you would like, how I manage my patients after 40 weeks of gestation. And that actually gets you off the hook, and the examiners may actually want to engage in that discussion. But no matter what, even if they don't, the important thing is, if you find yourself in that situation, be darn sure that you have worked this patient up in your mind, and you can actually discuss, according to reasonable guidelines, how you manage your patient at 40 and 41 weeks if you're going to commit to doing it and volunteering it for the examiners. So that's the easy way to get around that. Now, the other thing is, according to the ACOG publications, remember that 42 weeks is, we usually all try to induce our patients by 41 to 42 weeks. But ACOG says induction is recommended by essentially 43 weeks. So you can have a patient who's 42 to 42 and a half weeks, and that's not a medical indication for induction of labor, according to ACOG. These would all be elective inductions of labor. And again, the really important thing is being sure to use our terminology properly. In the examination, do not offer up the idea that 42 weeks is the cutoff after which patients have to be delivered. It is in fact 43. And that comes from data that shows that the risk of term fetal demise increases a little bit at 40 to 41, and a little bit more at 41 to 42. And then as you get to 43 weeks, it really takes off and skyrockets. And that is practice bulletin 146 if you'd like to check it out. Now, the other thing before we go to break is, and this is, again, I'm bringing it up simply because it is very common in the exam. All of us have inductions on our case list, and all of us have probably elective inductions, and some of us have inductions that are occurring at 40, 41, or 42 weeks. And particularly for elective induction, and particularly for elective cesarean delivery as well. The examiner may ask you, so how did you determine that this actually was a 39-week gestation? Is it important to do that? And your answer is yes, obviously. We don't want to do elective inductions below 39 weeks because of concerns about fetal maturity, which can vary quite a bit. And the examiner's next question is, so tell me, in this pregnancy, how did you confirm that this was actually a 39-week gestation, doctor, when you decided to induce her labor electively? And they'll say it in that kind of confrontational way like that. But what they really want to hear is, how do we understand how we can date a pregnancy? And that's all this is about. And it's a very basic thing, and it'd be common to come up in anybody's board exam. So let's go over that very quickly. First of all, we do want to look at menstrual dating. Is the menstrual dating reasonable? Does the patient remember when her period was? And has she had regular monthly cycles, or is there a fair amount of irregularity? And that's fairly useful. So you can identify a last menstrual period, and they were about every 4 weeks apart. We can use that for menstrual dating. Next is, when did she discover that she was pregnant? And these days with home pregnancy tests or HCGs, you want to find one that's at least about 36 weeks along. And that kind of points you toward a 40-week pregnancy, probably, or so. So if you can get a home or a blood pregnancy test identified that's maybe within 4 weeks after that menstrual period, that's really good dating right there. Next up is, we do first trimester ultrasounds. Remember that the standard error of measurement on a first trimester ultrasound can be up to 7 days or so. So now we have to take that into account. But if based on the error, it dovetails in with other things and gives you 39 weeks, that's useful also. Our fourth criteria, if we need to, is when did we first pick up a heartbeat with a Doppler? And we're looking for that usually at 10 to 11 weeks of pregnancy or so, and you can use that as well as the next criteria. Then the question that comes up is, well, doctor, suppose this patient didn't turn up in your practice until, what seemed to be like 7 months of pregnancy. How now do you know that she's a 39-week gestation? So we can't use any of those first criteria because they had to do with HCGs at 4 weeks, a Doppler at 10 weeks, first trimester ultrasound. We didn't get any of that stuff. So now we have to talk about our standard error of measurement on a second and third trimester ultrasound. And this is where it's important to know the standard error. So we're talking 10 to 14 days of standard error on a second trimester ultrasound, and probably 14 to 21 days, it's more toward 21 days as we get more toward a term pregnancy. And that is where then you have to go back to history. What does she know about menstrual dating? Did she have a medical encounter at any point at which someone said, hey, do you know that you're pregnant? And can we date when that was? And does that help us as well? And we're looking for sort of external criteria that can actually help us to focus in on an error range. And if we're not sure, we might actually not be committing to a 39-week induction. But if you look through in patients like that, you can develop a few things based on history. It may be medical encounters. It may be assessment of when fetal movement first occurred. They may be rough knowledge of menstrual dating or timing or things like that. And even if someone who turns up in the second or third trimester, you can probably get to within a couple weeks of error on dating a pregnancy at 39 to 40 weeks. And that's really all you need to do to persuade the examiners that you're taking good care of your patients and you're delivering them appropriately. Finally, before we go to break, just remember the misoprostol is, despite the manufacturer's warning, you can actually do it for cervical pregnancy. So I think we do want to go for a break. We have about a 10-minute break here, and then we're going to move on along. And I think our third session is going to be a little bit shorter than we've intended, just because we're moving ahead of time. So I'm going to get out of here for just a moment and go to some questions on Q&A. We have no questions. So I think let's go to a break. they have a previous spontaneous preterm. I think a multi-fetal gestation is an indication for talk about fetal growth restriction, loss of one twin, and similar things. So then how do we manage it? The basics are in pregnancy that we discuss the type of twinning as soon as we can and the risks with our patient and their management. Remember, multiple gestation is a low-dose aspirin indication. Want to have a little bit higher, maybe more caloric intake during pregnancy. Good screening for aneuploidy and anomaly testing, because we have two babies in there. The risk that one of them or in the pregnancy would be affected is higher than if you had a singleton pregnancy. And remember, your AFP cutoff is a little bit higher. And then what do we do with antepartum testing and delivery timing? Let's see, I'm going to go to this real quickly, just a second. Let's go back for just complicated di-di twin pregnancies. There is no recommendation for biophysical profile testing NSTs. However, the most recent practice bulletin from 2021 says it may be reasonable to perform antenatal testing. And that is according again to the one more page of notes here. I didn't want to let you guys know about this. So there are some stats that came out of that 2021 practice bulletin. IUGR with deaths of a single twin, IUGR is 5 times the risk of a singleton pregnancy. I've just read that in there as well. Twin reduction can occur in up to 1/3 of cases. Congenital anomalies, usually cardiac, are actually 2 times the risk of a singleton pregnancy. We have 2 babies in there. And they are usually cardiac or neural tube or GI issues like colonic stenosis, D, fistula, other stuff like that. Twin transfusion, again, the important thing about these mono to monodi pregnancies is remember that there is no normal fetus of any sort in these pregnancies. One may be at risk of fetal growth restriction and death from that. The other may be at risk of congenital heart failure and hydrops from overperfusion. And so that the surveillance for this, since these things can develop at 18 to 2 weeks of gestation, occurs much earlier. Mid-trimester diagnosis, mid-trimester onset of testing, which is usually the ultrasounds with monitoring Dopplers, and there usually be middle cerebral artery Dopplers in the mid-trimester of pregnancy if you have a monodi pregnancy on your case list. Good. So that, I think, is everything I needed to say about twin pregnancies. So let's go on to preterm labor. There's one really important thing that I do want to talk about preterm labor because it comes up all the time in the exam, and that is our U23 to just shy of 36 to 37 weeks of gestation improves the fetal outcome care facility, either for fetal care like a higher level NICU or for maternal care if there's a maternal comorbidity. And short-term tuberculosis, as long as both mother and fetus are stable for transport, and that's important, would be our third indication. Now, we have to talk about cervical shortening in cerclage and cervical insufficiency. So this is listed right here. These are the people with the previous spontaneous preterm birth. We do the cervical length screening every 2 weeks is reasonable from 16 to 24 weeks. And if you pick up a cervical length at less than 25 millimeters, you would offer them progesterone, which is why I've highlighted it right there. And then you would do a cerclage in someone who has actually had a rescue or exam indicated cerclage for a very high risk situation like a dilation of the cervix, or an ultrasound indicated cerclage in someone who had or had not been offered progesterone but was having significant cervical shortening. So the important thing is these days is that we do the screening every 2 weeks. First step is to offer vaginal progesterone if they have a previous spontaneous preterm birth and a shortened cervix, and then cerclage is the next step up from there. Remember that in twins, this is really the only reason it's up there, we don't do cerclages in twins. We don't do prophylactic cerclage in twins, and there's no evidence that progesterone is of, we don't do prophylactic cerclage. Vaginal progesterone is not indicated to be a benefit. We can do a rescue or exam indicated cerclage, and please line out on the bottom of the slide again the bit about 17-hydroxyprogesterone. Finally, this is just a reference slide, just because we talked about neuroprotection for preterm labor. Just know in your institution what's the protocol for doing magnesium sulfate, the dose, and the time to just be able to discuss that with the examiners. And finally, post-term pregnancy, and I think we're going to go to a break in a few minutes, and we're nicely ahead here. The one thing I wanted to mention here is, and this comes up every year, post-term pregnancy is a category on our case list. And it is surprising how often we do read case lists in which our candidates have put a pregnancy that is 41 weeks and some days in the post-term pregnancy category. But remember, the definition of post-term category is 42 weeks or greater gestation. Now, you may be someone who already has some 40 to 41 weeks, probably 41 week gestations in your post-term pregnancy category, and that is not a problem. What you want to do is recognize it right now, which is why we really are emphasizing pre-vetting your case list and going through this and identifying those cases so that in the exam, when the examiner says, I see here that under post-term pregnancy, you had someone who was 41 weeks and 2 days. Tell me, what's the definition of post-term pregnancy? You're going to tell them, well, it's 42 weeks of gestation. I recognize that this patient is 41 weeks of gestation, but she's in her 42nd week, and I didn't have people over 42 weeks. And I thought it would be interesting to have a patient in here so that maybe I could discuss, if you would like, how I manage my patients after 40 weeks of gestation. And that actually gets you off the hook, and the examiners may actually want to engage in that discussion. But no matter what, even if they don't, the important thing is if you find yourself in that situation, be darn sure that you have worked this patient up in your mind and you can actually discuss, according to reasonable guidelines, how you manage your patient in 40 and 41 weeks if you're going to commit to doing it and volunteering it for the examiners. So that's the easy way to get around that. Now, the other thing is, according to the ACOG publications, remember that 42 weeks is, we usually all try to induce our patients by 41 to 42 weeks. But ACOG says
battery low,
recommended by essentially 43 weeks. So you can have a patient who's 42 to 42 and a half weeks, and that's not a medical indication for induction of labor according to ACOG. These would all be elective inductions of labor. And again, the really important thing is being sure to use our terminology properly. In the examination, do not offer up the idea that 42 weeks is the cutoff after which patients have to be delivered. It's in fact 43. And that comes from data that shows that the risk of term fetal demise increases a little bit at 40 to 41 and a little bit more at 41 to 42. And then as you get to 43 weeks, it really takes off and skyrockets. And that is practice bulletin 146 if you'd like to check it out. Now, the other thing before we go to break is, and this is, again, I'm bringing it up simply because it is very common in the exam. All of us have inductions on our case list, and all of us have probably elective inductions, and some of us have inductions that are occurring at 40, 41, or 42 weeks. And particularly for elective induction, and particularly for elective cesarean delivery as well. The examiner may ask you, so how did you determine that this actually was a 39-week gestation? Is it important to do that? And your answer is yes, obviously. We don't want to do elective inductions below 39 weeks because we're concerned about fetal maturity, which can vary quite a bit. And the examiner's next question is, so tell me, in this pregnancy, how did you confirm that this was actually a 39-week gestation, doctor, when you decided to induce her labor electively? And they'll say it in that kind of confrontational way like that. But what they really want to hear is, how do we understand how we can date a pregnancy? And that's all this is about. And it's a very basic thing, and it'd be common to come up in anybody's board exam. So let's go over that very quickly. First of all, we do want to look at menstrual dating. Is the menstrual dating reasonable? Does the patient remember when her period was? And has she had regular monthly cycles, or is there a fair amount of irregularity? And that's fairly useful. So you can identify a last menstrual period, and they were about every 4 weeks apart. We can use that for menstrual dating. Next is, when did she discover that she was pregnant? And these days with home pregnancy tests or HCGs, you want to find one that's at least about 36 weeks along. And that kind of points you toward a 40-week pregnancy, probably, or so. So if you can get a home or a blood pregnancy test to identify that, that's maybe within 4 weeks after that menstrual period, that's really good dating right there. Next up is we do first trimester ultrasounds. Remember that the standard error of measurement on a first trimester ultrasound can be up to 7 days or so. So now we have to take that into account. But if based on the error, it dovetails in with other things and gives you 39 weeks, that's useful also. Our fourth criteria, if we need to, is when did we first pick up a heartbeat with a Doppler? And we're looking for that usually at 10 to 11 weeks of pregnancy or so, and you can use that as well as the next criteria. Then the question that comes up is, well, doctor, suppose this patient didn't turn up in your practice until, what seemed to be like 7 months of pregnancy. How now do you know that she's a 39-week gestation? So we can't use any of those first criteria because they had to do with HCGs at 4 weeks, a Doppler at 10 weeks, first trimester ultrasound. We didn't get any of that stuff. So now we have to talk about our standard error of measurement on a second and third trimester ultrasound. And this is where it's important to know the standard error. So we're talking 10 to 14 days of standard error on a second trimester ultrasound, and probably 14 to 21 days, it's more toward 21 days as we get more toward a term pregnancy. And that is where then you have to go back to history. What do you know about menstrual dating? Did she have a medical encounter at any point at which someone said, hey, do you know that you're pregnant? And can we date when that was? And does that help us as well? And we're looking for sort of external criteria that can actually help us to focus in on an error range. And if we're not sure, we might actually not be committing to a 39-week induction. But if you look through in patients like that, you can develop a few things based on history. It may be medical encounters. It may be assessment of when fetal movement first occurred. They may be rough knowledge of menstrual dating or timing or things like that. And even if someone who turns up in the second or third trimester, you can probably get to within a couple weeks of error on dating a pregnancy at 39 to 40 weeks. And that's really all you need to do to persuade the examiners that you're taking good care of your patients and you're delivering them appropriately. Finally, before we go to break, just remember the misoprostol is, despite the manufacturer's warning, you can actually do it for cervical pregnancy. So I think we do want to go for a break. We have about a 10-minute break here, and then we're going to move on along. And I think our third session is going to be a little bit shorter than we've intended just because we're moving ahead of time. So I'm going to get out of here for just a moment and go to some questions on Q&A. We have no questions. So I think let's go to a break.